Hi, I'm Dr. Oliver Sartor, and I'm professor at Tulane and have a variety of other responsibilities as well. I'm medical director of the Tulane Cancer Center. And this is going to be something a little bit new. It's a webinar on prostate cancer held via Zoom. First time we've done this, and I hope you enjoy it. And I'll try to answer a few questions along the way that I've received, but basically give an overview about prostate cancer. And it really has become a big field. I do want to say thank you to Clovis Oncology, who's helped sponsor the lecture and help us with some financial support for our philanthropy, which we use to support our prostate cancer research. I'm grateful to the Clovis Oncology Group. Managing prostate cancer takes a lot of skills today as compared to the past. And I point out this is in the near future, but it really is here today. Hormonal therapy has been with us for a long time, many decades, but targeted therapy is new. We have 2 new FDA approvals that occurred this year. Immunotherapy is evolving, and we have new markers and new ways of understanding immunotherapy. Chemotherapy continues to evolve. It's not a static field. Surgery has had improvements, and surgery remains a critical component to what we do, particularly for localized disease. Radiation oncology plays a role in many facets, not only in early treatment, but even in late treatment, in palliative treatment, and targeted treatment after PSMA scans. So radiation oncology is adapting to sort of a new normal. Nuclear medicine is evolving rapidly, particularly with the onset of PET scans and anticipated FDA approvals. Molecular pathology and understanding tumor genomics, as well as genetics of the patients themselves. All of these are playing into our decision-making today. And quite frankly, I think we're practicing better medicine than we ever have before. Let's talk about a little bit of background first. Prostate cancer is the most common non-skin malignancy in the U.S. men. These are the estimates from the American Cancer Society in 2020. As you can see, the estimated number of new cases is about 191,000. That is smaller than breast in females, but when it comes to non-skin malignancies, everything else is far behind in men. You can see colorectal, 78,000, lung and bronchus, 116,000, urinary bladder, 62,000. So it's a common disease. It affects a lot of men. It's about 21% of the cancers that are diagnosed in the United States in men each year. Now, some people, I think that prostate cancer is always a relatively benign disease, something that elderly men get, and they die not from prostate cancer, with prostate cancer, but actually about 33,000 men each year in the United States are going to die from prostate cancer. It's actually the second leading cause of cancer death. And if you do not smoke, it actually is the leading cause of cancer death in men in the United States. And by the way, don't smoke. That's bad on multiple fronts. Not only lung and bronchus, but also pancreatic and urinary bladder and esophagus and a variety of other cancers are increased by smoking. So if you do smoke, you should really consider quitting. The incidence mortality ratio is relatively favorable in prostate cancer. And what this means is how many men get it and how many men die. So it's about 6 to 1 of the people who get it and those who die. That's the same as breast, about 6 to 1. So much better than, say, colorectal cancer, lung cancer, and pancreatic cancer. Pancreatic cancer is a really tough one. It's almost 1 to 1. There are very few survivors from pancreatic cancer. Lung cancer's had improvements. It's about 2 to 1. Colorectal is about 3. So about 3 men will be diagnosed for every one that will die. For prostate, it's 6 to 1. So that is a pretty good ratio. One of the things that has generated some controversy, and I'll address only briefly the controversy of PSA screening. PSA screening has decreased the incidence of metastatic disease. This is from the New England Journal about 5 years ago. And you can see when there was the onset of widespread PSA screening that the incidence of metastatic disease went down. By the way, PSA, in my opinion, is a better test for prostate cancer than is mammography for breast cancer. Everybody talks about mammography and how good it is. PSA, in my opinion, is actually a better test. but there's a price to pay for PSA, and it's over-treatment, over-diagnosis of indolent cancers. PSA is not specific, and PSA is particularly going to lead to diagnosis of cancers that don't necessarily need to be treated, and that is a problem. So I would like to say that I support PSA screening, and I get my own PSA checked, and that probably tells you what I think about it. But I will also tell you that if I get diagnosed with a low-grade cancer, that I'm going to go on surveillance. I'm not going to be treated. So we have to understand who needs treatment and who doesn't need treatment. Now, this has sort of led to a paradigm shift. Starting in about 1989, 1990, we started getting these screening PSAs and doing a digital rectal examination. And if we found abnormalities in either one, we'd do a biopsy. And what was happening is we decreased the risk of metastatic disease. But on the other hand, we detected all of these cancers that are not necessarily going to benefit from treatment. And so now we're changing our paradigm, and we're asking the question, what testing should we get before the first prostate biopsy? And I actually could go into some detail on this, but the one that is most important is an MRI. Today, when feasible, if I have a patient with an elevation in their PSA, I try to get an MRI before I do the biopsy. And I'll show you the data here in a second. And we have a grading system called a PIRAD system, 1, 2, 3, 4, and 5. If the MR shows a PIRAD with a score of 3 or more, then it's very reasonable to biopsy. But if the PIRAD is 1 or 2, then we don't even biopsy, unless there's some other abnormalities that might need to be accounted for. And as a consequence of using the MRI first, we actually are doing fewer biopsies today, but the biopsies we do are more accurate. We're using the MR-guided biopsy in order to find the areas that are most likely to be cancerous. And we're finding more significant cancers at the same time we're doing fewer biopsies. So that's good. Now here's the PIRAD grading system. This is based on the New England Journal from May 10th of 2018. Very nice paper, by the way. And here you look into the PIRAD scores, and they have the PIRAD 3, 4, and 5. Well, if you have a high PIRAD score, and that'll be a 5, it turns out that clinically significant cancer, which is the cancer you want to treat, is going to be detected about 83% of the time. If you have a PIRAD 3, the clinically significant cancer is only going to be detected about 12% of the time. And by the way, not everybody has cancer, even if they have a high PIRAD score. Most patients do, but not everyone. So we do need to do a biopsy. We don't just do an MRI and then initiate treatment. We still have a role for getting the biopsy done. Now, prostate cancer can be divided in various clinical states, and this is really going to form the basis for the rest of the lecture. In broad terms, we have the hormone sensitive, and we have those patients that are recurring after initial hormonal treatment. That is a big difference. And so we have to know if the patient is hormonally treatment naive or whether or not they've recurred after hormonal treatment. So that's a big split. And then, of course, we can divide things into the localized disease, those people that have recurred after localized therapy, those patients that may have been treated with hormones and then begin to relapse, those individuals who have metastatic disease as demonstrated by various scans or not, whether or not they've had chemotherapy or not. And this sort of paradigm is set up so that we now have treatments for each particular subset of patients. And so somebody comes in and says, Dr. Sartor, I have prostate cancer. What should I do? Well, the first thing I might say is, well, have you had any prior treatments? Or what's your PSA? And what's your Gleason score? And have you had any scans? And so there's a whole variety of questions that we need to get to before we really determine treatment. I'm going to start off by discussing localized disease, cancer that appears to be confined to the prostate, and coming through those options. And here's how we think about it. So localized disease is mainly about risk stratification and life expectancy. We need to know the Gleason score. We need to know the PSA. We need to know the clinical stage. We need to know the extent of the cancer as determined by the biopsy. I generally like to know what the MRI shows. I like to know about the family history. I may or may not want to know about genetics and transcriptomics. I'll explain more about that in a minute. I need to understand about the age of the patient, the coexisting medical conditions. I'll state something obvious. If you're 99 years old and in a nursing home, it might be a little different than if you're a 49-year-old marathon runner. And so just because we understand aspects about the cancer, that's critically important. We also need to know about the patient, need to understand what their health overall is and understand about their life expectancy. We'll start off by talking about Gleason score, because this is the most important variable for those with localized disease. Dr. Gleason was a pathologist. He practiced up in Minnesota in the 1960s, and he was writing about prostate cancer, and he would look at it under the microscope, and he said, well, some of these cancers just have these small uniform glands, and some of these cancers don't even have glands, and it looks like sheets of cells. And some of the cancers are kind of in between, and he worked out a grading system, and he called it 1, 2, 3, 4, and 5, depending on how it looked under the microscope. But he also noted that there was a distinction between one area that he might be looking at under the microscope and another. It didn't always look the same. In one place, you might see one thing, and in another place, you might see something else. So he came up with 2 scores. Now, the first score was the one that was the most common cancer that he saw under the microscope. But if you looked around and saw a different type of cancer, a different pattern, he would also score that. And that's why we have 2 scores. If you see a 3 plus 3 is equal to 6, well, that means you look around and all you see is the 3s. On the other hand, if you see a 3 plus 4, then you know that mostly you see a 3 under the microscope, but you also see some pattern 4. Or you might have a 3 plus 5 or a 4 plus 3. And that's very, very important, because that tells us what's going to happen to the future. This is in the pre-PSA era. These are patients who chose not to be treated. And you can see that cancer-specific survival over time, we have 15 years of follow-up here. If you have a Gleason 2 to 4 or a 5, virtually nobody died from prostate cancer, even if they didn't have any treatment. And if you had a Gleason 8, 9, or 10, you can see that everybody died. And so there's a big difference between the Gleason scores. And today we've adapted the Gleason score. It's not exactly the same as what we used to do, not the same as what Dr. Gleason did, but nevertheless, it turns out that it's a very, very important variable. Now, this is a new Gleason grouping in which we call different grade groups. And a 3 plus 3 is equal to 6 is now a grade group 1, and a Gleason 9, 10 is a grade group 5. And we create these follow-ups because you can see the prognostic difference. These are not patients dead or alive. These are patients with PSA relapse after surgery. And you can see that if you operate on somebody with a Gleason 9, 10, well, 10 years later, the relapse, which is going to be the inverse, the probability of relapse-free survival over there, the relapse rate is going to be over 80%. Whereas you have a Gleason 3 plus 3, the relapse rate's only going to be about 10%. So understanding the Gleason score is very important for understanding prognosis. And you have to understand that the higher the Gleason score, the worse the prognosis, and maybe even the more intensive treatment you ought to receive. Now, conclusion, Gleason score, determined by biopsy or after surgery. And you have to have tissue. You have to look at the cancer under the microscope. Is the most critical factor in determining prognosis for patients with localized disease. But there's also staging. That's how far the cancer is spread. This is a combination of exams and scans. First of all, you do a digital rectal exam. You feel the prostate. If you don't feel any abnormality in the prostate, we call that a T1. That means you can't feel it. T2 means you feel it, but it seems to be inside the prostate. T3 means you feel it and it seems to be coming outside the prostate. And T4 means it's outside the prostate and invading the other organs. And then we try to grade the lymph nodes. Are they positive or negative? And positive means they have cancer. And then you look at the distant sites. We put together this so-called T&M staging. And if you're M1, that means you have metastases. That's a whole different category, and we'll deal with that in a second. If you're confined, then we talk about organ-confined cancer. And then if we're talking about pelvic lymph nodes, that's sort of regional metastases. So these are all different ways that we might view this. Now, when we look at the patient initially diagnosed for those with localized disease, we come up with what we call a risk stratification score. And we put people into low risk, intermediate risk, and high risk. And if you're low risk, that means you've got a T1, means you can't feel it, or a T2A, means you can barely feel it, and a Gleason 6, which is as good as it gets, and you have a PSA of 10 or less. But you have to have all the above. You have to have a localized prostate cancer on exam, Gleason 6, and a PSA of less than 10. Now, the high risk localized is if you do the exam and you feel like that the cancer is starting to get out of the prostate, or you have a Gleason 8 to 10, or you have a PSA greater than 20. Any one of those factors will put you into high risk. And then intermediate risk is a catch-all term for everything in between. Treatment considerations are basically as follows. For low-risk cancer, we typically use surveillance. And no treatment has ever really been able to show benefit. If you've got a low-risk cancer, you got a Gleason 6, PSA less than 10, T1C on the staging, we really prefer not to treat because all you'll get is side effects from the treatment. We don't necessarily have benefit. On the high-risk patients, we typically use surgery or radiation plus hormones, radiation plus seeds plus hormones, and we do not use surveillance. The intermediate risk, occasionally we use surveillance if it's a favorable prognosis and the age is right, but typically we use surgery, seeds, radiation, plus or minus hormones. So it kind of depends on the age and comorbidities of the patient, as well as the risk of the disease. Remember that 99-year-old nursing home patient and that 49-year-old marathon runner are not the same. We have to take that into account when we start recommending treatment. Now, surveillance we typically do for low-risk cancers. And here's the 10-year outcomes after monitoring for surgery or radiotherapy or surveillance. And by the way, I'm not sure surveillance was optimally done here. On the left-hand side, there are actually 3 curves there. This is prostate cancer-specific survival. After 10 years, whether or not you're actively monitored, have radiotherapy, or have surgery, the survival is 99%. So hardly anybody dies. But remember, these are predominantly low-risk patients. These are not the Gleason 8, 9, 10 patients. Those patients have trouble. Now, freedom from disease progression was determined by scans. And you can see the surveillance, and that's the dotted line there, has had more disease progression. But in this study, which was done in England, I'm not sure that it was done optimally, the surveillance. They weren't using MRI, and I'm not sure that they do surveillance the same way that I do surveillance. What I'll say is that the reason you don't treat everybody with low-risk disease is that if you're using these local therapies, typically surgery and radiation, that urinary and sexual dysfunction are fairly common. Now, on the left-hand side of the screen, these are incontinence scores, and that's surgery, and you can see that can be incontinence with surgery. That's urinary leakage. And here you have problems with sexual function. This is erection firmness, and you can see that there's a decrease after surgery and then a very slow and very modest recovery. You never get back to baseline. On the other hand, remember, these are averages. They're not, they're exceptional individuals, but these are averages. This is hormones plus radiation right here. You can see an abrupt decline, and then over a period of time, it sort of equalizes with the surveillance crowd. And by the way, erectile firmness does have a tendency to decrease with age, so that can be a problem in aging men in general. Now, at Tulane, and I must admit, I haven't formally analyzed our surveillance. We have about 400 patients now, mostly with a low-risk disease, usually with a MRI pi rate of 3 or less. Occasionally use some genetic risk scores to help make a decision, things like Decipher Polaris and Oncotype DX, and these are ways of looking at things sort of beyond the Gleason score. We don't always use it, but sometimes we use it if we kind of have a tweener. We get PSAs about every 3 to 6 months, exams every 6 to 12 months, and MRI yearly, and biopsy is needed. We've had very good success with this. If we follow our paradigm, the outcomes are quite good. Yes, we do treat people. Yes, probably 30% of patients, maybe even as many as 40% of patients eventually require treatment. But nevertheless, it turns out that treatment can be avoided altogether in a significant subset of patients, and treatment can be delayed in another subset. We believe that that delay can be done safely. What about high-risk cancers? Totally different story. Here we need surgery or radiation plus hormones as the standard of care. And this is an example of radiotherapy alone. This is an old study, but it's a good study. What was shown here is that radiotherapy alone is inferior to radiation plus hormonal therapy. You need to get the two together to create the synergy. This is with 3 years of hormones. We've been able to drop that down to about 18 months for many men, and 24 is considered a standard by others. The bottom line is that radiation plus hormones is one way of approaching these high-risk individuals. Surgery is another way to approach them. We need to treat these individuals, and if we don't, there's a price to pay and survival is diminished. Now, one of the things that we have been evolving is imaging. For years, we've done CAT scans, bone scans, and MRIs. And I'm here to tell you that how much you find depends on how you look. The bone scans and CAT scans are far from perfect. And at times, we end up with relapses simply because we didn't have accurate imaging. CAT scans and bone scans are sensitive to down to about 1 centimeter worth of tumor. But 1 centimeter worth of tumor is about 1 billion cells. We really need to do better. Now, the PSMA PET scan, which I'm going to talk about here in a moment, is better, 20 to 100 times better. But it too is not perfect. We do not have perfect imaging, and I don't think we're ever going to have perfect imaging. We're never going to be able to image 10 cells. And even when we're looking at PSMA PET, it's vastly superior to where we were in the past, but it's still not perfect. Now, this improvement in detection of disease is involving the PET scans. The PSMA PET is the most sensitive, but it's not FDA approved. I'll talk about that more in a bit. Fluciclovine or Axemin is FDA approved, but typically only in the recurrent setting. A lot of people talk about PET scans, but they're talking about FDG PET. FDG PET is not particularly good for initial staging. We don't use it. And all I'll say is that we need to have an evolution in our imaging. And the good news is I think we're going to get there. This is a PSMA PET. There is uptake in the salivary glands, in the kidneys with what I'm going to call the conventional PSMA PET. It gets excreted into the urine, but you can pick up these spots. Pick up spots in the lymph nodes, pick up spots in the bone, maybe in the liver. Here you see a patient who has a spot here in the liver. They have spots that are in the lymph nodes. They have spots in the bone. So those are not what you want to see. You don't want to see that extensive a spread, but at least we know that it's there. And conventional imaging may not always pick up these lesions. Fluciclovine or Axemin PET is FDA approved, but we're having trouble with insurance reimbursement. Right now, Medicare will pay for it, but only for recurrent disease. And we can use this in our treatment planning, but at the same time, it's problematic because getting a fluciclovine for a newly diagnosed patient is not only not well studied, it's very problematic in terms of reimbursement. Now, next I'm going to talk about the patients that have a rising PSA after they have received local therapy. And we use either salvage treatments, and that can typically radiation, androgen deprivation, that's hormonal treatment, or no therapy at all. Now, when we look at recurrent disease after surgery, it's important to know the salvage radiation provides the second and maybe last chance for cure. So people have a little PSA, and by the way, if you don't have a prostate, you should have no PSA. You should have 0 PSA if you don't have a prostate. So you get a little PSA of 0.2, 0.3, and people say, well, what's the danger? And there may not be much danger now, but the truth is that means you're not cured in the vast majority of cases. And salvage radiation presents the only opportunity to cure you in the vast majority of cases. Now, the PSA doubling time, I'll talk about that in a moment, and the PSA value at the time of radiation are critical for prognosis. Low and slow is good. So low PSAs are good, slow doubling times are good. We have a little bit of a debate about whether or not hormones should be added to radiation, but if there's a consensus once the PSA gets above about 0.7, a little more debatable when you get lower. But at the same time, there is some evidence to suggest that hormones radiation together may give better at least 5-year relapse-free survival rates as compared to radiation alone. Now, this is the effect of salvage radiation, no hormones, by the way. And the effect of radiation depends on the PSA level at the start of radiation. So here we're looking at the patients without progression. Here, 1.0 means nobody's progressed. 0 means everybody's progressed. And you can see these different curves. This is a PSA of greater than 1.5. This is a PSA of less than 0.5. And you can obviously see there's a better outcome for those people with the lower PSA at the time of treatment. And actually, I prefer much lower. I mean, if I'm following a patient and I'm convinced there's a rise in PSA, I'll be radiating at 0.11 or 0.12, something like that. I don't wait for it to get to 0.5, and because we have worse outcomes. So you can do better. In fact, I can cite some recent data at 5 years, which would be 60 months on on this data that if you use radiation hormones in a broad field, you might get up to 91% no relapse if you do things right and catch it relatively early. So when you radiate is very important. And that's why we follow people carefully after radical prostatectomy. Some people say, hey, my treatment's done, doesn't matter, you know, whatever. But it's not true. If you relapse, you want to catch it early. Now, survival after PSA recurrence, this is old data, but nevertheless, it's good data. It's highly dependent on the PSA doubling time. Occasionally, we will not do anything at all. If you have a PSA doubling time of greater than 15 months, you can see that 10-year survival is going to be greater than 90%. On the other hand, if you've got a PSA doubling time of less than 3 months, by the time you get out to about 13 years, everybody's dead, and the median survival is only about 6 years. Now, we're doing better. This is old data, but nevertheless, it shows the point. How fast your PSA doubles is an important parameter. And again, a slow PSA doubling time is good. Recently encountered a case where the PSA doubling time was about 24 months. My remark was, don't do a damn thing, just watch it. We don't have to do anything. It's not a danger to you anytime soon. Now, we're using this more sensitive imaging, and it's creating a little bit of a conundrum because the scan sensitivity is still suboptimal. The scan in terms of PSMA, which is our best PET scan, is typically around 50-50 when you get to be a PSA of about 0.5. But optimal salvage radiation is probably before you get to 0.5. So we'd like to wait and then scan somebody, but the problem is we may be losing a window of curability. Another problem is the PSMA PET is not paid for by insurance today. I do think the FDA approvals will be within a year, and there are multiple submissions ongoing right now. Fluciclovine, which is FDA approved, is often paid by Medicare only. You have to fight with your insurance company. It doesn't always work. So what we've been doing is getting people to travel and spend about $1,250 to $4,600 in order to get it. We've been sending people to a variety of places. Don't need to endorse any, but I'll say UCLA has been my favorite out of Los Angeles. It is less expensive in Europe and Australia. And if you happen to be going to Melbourne, then we can get you a scan at about $600 or $700 Australian dollars, and that's a pretty good exchange rate right now. Why are we interested in finding out where the cancer is? Well, this is data from UCLA, and what they did is they took patients who had recurred after they had their initial therapy, and they found out where the lesions were on the PET scan, and then they would either do surgery, radiation, or occasionally cryoablation. And here's the PSA declines. You can see that the majority of patients had good PSA declines. And it's a little bit deceptive. Let me tell you why. Because this is a highly selected series. There are a whole bunch of people who did at the PSMA scans and they couldn't see anything. There are a bunch of patients who got a PSMA scan and they saw too much. So this is only kind of a window into the world of PSMA recurrences, but it does show you that some patients can do well with regards to PSA declines. By the way, there's nothing in here about duration. Some of these people have a great response, and before you know it, 2 months later, they're back up again. So it's probably a little bit of an optimistic view because it's patient selection as well as no time durability shown in this particular graph. But a lot of patients do have good responses. Now, next I'm going to be talking about these patients with overt metastases. These are bone scans and CAT scans that are positive when they come in. And here we have a variety of new data looking at ADT plus chemotherapy, androgen deprivation, chemo, abiraterone, one of our new hormones, apalutamide, one of our new hormones, and enzalutamide, one of our new hormones. And so we think about it. But one of the things we've learned, and this is from a New England Journal article in 2016, is a substantial minority of these patients will have some type of alteration in their genetics. And this is potentially important. In this study, about 5.8% of men had a change in their BRCA2 gene. Well, BRCA2 gene is a pathogenic gene associated with risk of prostate cancer, and by the way, not a very good prognosis either. And there's CHEK2 genes, ATM genes, BRCA1 genes, RAD51D, PALB2. You can see relatively small percentages, but 11.8% of men have metastatic disease. And now our guidelines suggest that for men with metastatic prostate cancer, we ought to get what we call germline genetics, because that tells us about whether or not any of these particular mutations might be present. By the way, 4.6% of men with localized prostate cancer. So the risk of finding one of these abnormalities is higher for those with metastatic disease. Now, this is one of our little papers, and we published it later. This is just a presentation. And here we looked at the mutations in a little bit broader sense than was shown in that prior study. And the findings are pretty similar, though. We had BRCA2 mutations, about 5% of our samples out of 1,158 samples. CHEK2 was 2.7%, ATM 1.6%, BRCA1 1.3%, HOXB13, which was not tested for on the New England Journal paper, 0.7%, and then some other genes that are there. There are also some rare mutations, you know, FANK-A. Here's this one right here, BRIP1. These are important, but they're rare. So we look for those rare mutations today. Now, why are these things important? First of all, they often confer a poor prognosis in early age of onset. If you knew before you were diagnosed with prostate cancer that you had one of these things, you definitely will want to be under very careful surveillance. There's also risk of additional tumors. It's not just prostate cancer. In men, it can be things like pancreatic cancer. In women, it can be much more, as implications for future treatments. I'll be covering that in a bit. We have these things called PARP inhibitors and PD-1 inhibitors that we use under specific circumstances, as implications for family members, particularly for females. Women who've got a BRCA2 mutation are going to be developing breast cancer about 70% of the time and 40% for ovarian cancer. They may even have prophylactic surgery. And there's elevation of the prostate cancer risk if your son might have one of these alterations, or if your brother might have one of these alterations. So it's important to understand these germline mutations, not only for the patient, but also for the family. Now, let's talk about therapy a little bit for those patients who come in with overt metastatic disease. And the first big breakthrough we had, some Chris Sweeney and colleagues who did this important study looking at chemotherapy with docetaxel. And they gave androgen deprivation plus chemo and found a median survival of 49 months versus 32. That may not sound much, but I can assure you that these patients are glad to have an opportunity to have a little better survival. This hazard ratio of 0.6 means it reduced the risk of death by 40%. It's an inverse. So a hazard ratio of 0.5 means it drops the death rate by 50%. Hazard ratio of 0.6 drops it by 40%, the death rate. Hazard ratio of 0.7 means you drop it by 30%. We'll see these hazard ratios because that's how we talk in medicine today. Now, the next big study, and there were a couple of them here, used abiraterone. And abiraterone is a hormonal agent. It's not a chemotherapy. And what it did is it prolonged overall survival. And by the way, just last week, we had an update on this, on the abiraterone treated patients from a study called Stampede in the UK. And it turns out that the risk of death was reduced by about 40%. Here we see a 38% reduction in death. And if we look at the PSA differences, it's really quite dramatic. When it say placebo here, this is not really placebo. This is normal androgen deprivation therapy, the stuff that we've been using for years. Here's normal androgen deprivation plus abiraterone. Here, you've got a time to relapse by PSA of about 7 months. Here, you've got a time to relapse about 32 months. Well, this is extending it out about 4 times. That's a huge difference in time to PSA progression. And very few of these patients who had no PSA progression advanced by scan. So PSA is a pretty good marker here. Now, it's not just abiraterone. There are things like enzalutamide, which is another hormonal therapy. This is a study presented at ASCO 2019. ASCO is American Society of Clinical Oncology, one of our big meetings, one I try to go to every year, except this year when it was virtual. Now, the hazard ratio here is 0.67. That's pretty good. It means reduce the risk of death by 33%. And the study follow-up was not very long. Here's another drug called apalutamide, another hormone. This reduced the risk of death by 33%. So these are positive studies. And in fact, they're all positive studies. So now what do? Do we give docetaxel? Do we give abiraterone and ADT, apalutamide and ADT, enzalutamide and ADT? I'll simply say that they're probably all good. In the UK trial called the Stampede trial, there was similar survival benefit for abiraterone and docetaxel, but the abiraterone had a better time to progression. And then the question arises, well, what about if we put everything together? What else? We give chemotherapy, if we give abiraterone, we give enzalutamide, or we give The docetaxel, we put it together. We use novel hormones and chemotherapy and ADT together. Is it better? So far, we have no evidence that that is the case. So we don't use triple therapy. We only use doubles. And that's something that'll be explored further in the next year or two, looking at these triplets in a little more detail. Now, I'm going to spend just a brief moment about this next disease state, if you will. These are patients who've had androgen deprivation, so the testosterone is low, and they progress. And you do scans, and you don't find anything. This is called non-metastatic castrate-resistant prostate cancer. The non-metastatic disease now has 3 FDA approvals: enzalutamide, darolutamide, and apalutamide. All of these are hormones, and all of them are fairly similar. There's a big benefit by adding the hormones early, which we found out recently. In fact, there's one of these articles with darolutamide showing a survival benefit, was just published on September the 20th, so just a few days ago, showing a good survival benefit. But nevertheless, we're adding in hormones more frequently. If you think about this non-metastatic category, however, if you did PSMA scans, you would find PSMA positivity in the vast majority. And that's creating a whole new paradigm, because now we don't necessarily know what to do with these molecular imaging patients. Yes, we can treat them with hormones, but maybe we ought to be adding in radiation or something for their metastatic disease as well. That's something that'll have to be determined. Then we do the patients who have developed what we call radiographic metastases, and these are the typical bone scan CAT scans, and they're resistant to ADT. And traditionally, we've grouped these patients into the pre-chemo and the post-chemo and the chemo settings. And we have abiraterone, enzalutamide, and the radium-223 approved in this setting. Simple cell T is another immunotherapy. And then recently, in May of this year, we have 2, and I'll introduce a new term called PARP inhibitors to you, rucaparib or olaparib, and also pembrolizumab, which is an immunotherapy for some genetically selected cancers. So I'll touch on this to help give you a perspective on how these new therapies are impacting patient care. Now, I'm going to talk about this CRPC, the castrate-resistant prostate cancer, next. These are the big trials, and I don't necessarily mean you to read these. I certainly don't think you ought to memorize them. But what you'll see, these hazard ratios about 0.79 right here. That means a reduction in the risk of death by 21%, down to this one, which is 0.63, which is about a 37% reduction. And we have a variety of these trials which have shown some benefit. And some people will say, well, hell, it's not much benefit. It's only a couple of months. These trials are a little bit deceptive, because oftentimes there's crossover, meaning the patients were treated with a placebo initially, but then they were not treated with placebo. And there are things that go on that are not always apparent to the eye. You need to dig into it a little bit before you decide that these are not significant changes. They often are more significant than they appear. Now, I am continuously asked, how do I make treatment decisions in the clinic? This is what everybody wants to know. And this is just a little bit of a list, and I don't mean that it's a complete list, but these are the factors I'm trying to take into account. What about the availability of the drug? Well, drugs are great, but you have to be able to afford them, and sometimes these drugs are not affordable. What about the genotype of the tumor? That's new. We need to know. What about the availability of clinical trials? Sometimes clinical trials can be a great choice. What about your performance status? That means how well are you getting around? That's that nursing home patient versus marathon runner. What about the 99-year-old versus the 49-year-old? What about other medical issues? What if you have horrible congestive heart failure? What about your laboratory assessments? What about your white count, your platelets, your liver function? Do you have symptoms or no symptoms? If you do have symptoms, where? How much? What about your prior therapies? Were you resistant to them, or did you respond to them? You have great response to your first hormone, no response to your first hormone. That influences how I think going forward. What about tolerance and intolerance of prior therapies? Some people may have had chemotherapy and they did horribly. Other people take chemotherapy and they say, it's fine. So depending on the tolerance of prior therapies can influence my future therapeutic choices. What about the burden of disease? Do you just have a couple little metastases, a couple little spots on the bone scan? Or do you have 49 spots on the bone scan? That makes a difference. What about the location of the disease? Is it bone only? Is it in the liver? And liver is particularly bad. It turns out that the location of the disease can make a difference. What about the pace of the disease? Is it going fast or is it going slow? When it progresses, is it just progressing in one spot or is it progressing all over? And by the way, not all prostate cancer is the same. There are adenocarcinomas, which is typical, and then there are these anaplastic things, and then there are neuroendocrine things, and there's small cell things. That has to be taken into account. And of course, patient preferences count. So if you want to come to my clinic and think about me making decisions, these are the factors that I'm taking into account when I'm trying to decide what is the best therapy for you. And I'll simply say, I do it quickly and I don't go through everything in a loud way. The good news is I've been doing this for 30 years and I can pretty intuitively make the choices. But nevertheless, there's a lot of factors that go into good decision making. Now, when it comes to treating these patients with relapsed post-hormones, the androgen receptor, which is hormonal therapy, remains the #1 target. And I'll simply say that abiraterone and prednisone and enzalutamide are the most important new therapies in the last decade because so many people can benefit from these type of therapies. They're very important, and we try to make sure that virtually everybody has the opportunity to try them at some point. But it turns out that we have crazy ideas as well. And one of the crazy ideas that we have is high-dose testosterone. And I don't want to take too much credit for the crazy idea because there were crazy people at Hopkins before me thinking about it. And the guys at Johns Hopkins really deserve the credit. They're disrupting the paradigm, and I do respect them for doing that. So here's an example of one of their publications. They term it bipolar androgen therapy. They make the testosterone go up and then it comes down. By the way, I happen to have evidence to say that it doesn't always have to come down. If you just get it up, it's probably good enough for some. These are PSA waterfall plots. Up is bad, down is good. You can see that a number of patients will respond with a PSA decline to receiving high-dose testosterone. Completely counterintuitive. But this is the Hopkins work, and they've given us an insight that we didn't otherwise have. So bravo to them for being brave and trying this. And then, if you've gone on the high-dose testosterone, you can come back and potentially be sensitized to some of the other therapies. And that makes it a little bit interesting too. So your hormones become good again. Now, one of the things that we're doing right now that's very important is begin to understand the genomic heterogeneity of prostate cancer. And it turns out, if you look at the genome, that there are lots and lots of variability. Each one of these is an individual genomic alteration. Turns out all the patients are a little different. Things are common, like androgen receptor alterations, another gene called TP53, another gene called PTEN. There are things called FOXA1, et cetera, et cetera. But one of the insights derived from this tremendous piece of work was DNA repair defects are present in about 20% of men, and that's a pretty significant number. And right now, we have these other, what I'm going to call druggable targets other than the androgen receptor. So DNA repair genes, BRCA2, BRCA1, maybe PALB2, RAD54L, RNase H2B, etc. And we can use these things called PARP inhibitors to be able to induce responses in patients who have these selected genetic defects. We have to look for the genetic defects before we can use the drug. Then there are these genes that are associated with something we call mismatch repair, MSH2, MSH6 being the two most common, maybe CDK12. And we can use newer immunotherapies. This is code word here for immunotherapy, PD-1 and anti-PD-L1. That's the mechanism whereby these new immunotherapies work. We have a number of patients who have PTEN loss, and there's experimental data just presented, by the way, at ESMO, the European Society of Medical Oncology, just last week on AKT inhibitors. Not super impressive in my mind, but nevertheless important because it represents a new pathway that we might be able to take advantage of. And PSMA radiopharmaceuticals using the PSMA type scan, but now delivering a therapy, experimental but important. So let me talk a little bit about these for a second. First of all, I want to emphasize that this is not pie in the sky. We have FDA approvals for the PARP inhibitors. Rucaparib got an accelerated approval on May 15th of this year. Olaparib, one of the other PARP inhibitors, got approval on May 19th, so neck and neck. There were a little bit of differences in the approval. Rucaparib was approved for these alterations in either the germline, that means the DNA you're born with, or somatic, that means the DNA in the tumor, BRCA1, BRCA2. And you had to receive both chemotherapy and novel hormones. The olaparib was a germline BRCA1 and BRCA2, but then a whole variety of other genes were included in the FDA approval, and these were individuals who could have treatment after novel hormones alone. So it turns out, and I'll simply say, I think the FDA got quite enthusiastic by including some genes where we don't have a lot of activity. The CDK12, for instance, is not a great gene for PARP inhibitors, in my opinion. And some of the other genes, we have pretty minimal data, like, check 1, check 2. Don't have a lot of data here. On the other hand, things like the PALB2 looks pretty good. And we have interesting data, preliminary, with RAD51B, RAD54L. So there are things that do seem to work, and then there are things that don't seem to work. Now, here's the Triton 2 trial through Caparib, one of the PARP inhibitors. Disclosure, this is Clovis, the one that's sponsoring the lecture. But I'm showing you here objective data. They're looking at a variety of these gene mutations. And here they're looking at the response. Now, these are changes in tumor volume. These are the CAT scans, and they're shrinking. So these are responses as measured by radiographs or CAT scans. And what you can see is that a number of patients had shrinkage of their tumors, and particularly the BRCA1, BRCA2, not the ATM, by the way, but they have shrinkage of the tumors as measured by the CAT scan. And this data led to the FDA approval for the BRCA1 and BRCA2 for the rucaparib. So that's important. Now, this is the olaparib, which has just been presented at ESMO, the European Society of Medical Oncology, last week. And it hadn't even been a week at this point. But at the same time, this is published in the New England Journal simultaneously. And you can see we got a little Tulane involvement here, but I played a small role. People like Maha Hussein and Yohan de Bono played a big role. I just had a small role, but nevertheless, we were able to get on the author line. And here you see the survival. This is not measuring tumor shrinkage. This is survival in cohort A, which is a combination of BRCA1, BRCA2, and ATM. Most of this data was driven by the BRCA genes, not so much by the ATM. But you can see that patients lived longer. Here, the hazard ratio for death was 0.42. That means a 58% reduction in the risk of death. That's really good. And these are patients that had crossover. It gets to be a little bit elaborate. Nevertheless, these are the patients who were taken into account for the crossover, and a 58% reduction in the risk of death is good. So now we have 2 PARP inhibitors for those with BRCA mutations. That's important for those who have BRCA mutations. Now, it also turns out that there's some older therapies, one called platinum, this is a chemotherapy, one called carboplatin, that may have activity as well. These are my friends up at University of Washington in Seattle, done a great job looking at carboplatin in these patients. And this is an option as well for some patients who can receive chemotherapy but may not be able to afford a PARP inhibitor. That's another issue. They're quite expensive. New immunotherapies. I'll say that everybody wants immunotherapy. Me too. I want immunotherapy. But we have indications. Pembrolizumab, which is a PD-1 inhibitor, one that is quite famous. Jimmy Carter's been on pembrolizumab, and lung cancer responses have been quite remarkable. Pembrolizumab is FDA approved for tumors in the prostate that are MSI high, have a high tumor mutational burden, or mismatch repair deficient. So it's not all tumors, it's only selected tumors. Here's an article that we published in something called The Oncologist, and we talked about these things. So MSI high is present at about 2.4% of primary tumors. Mismatch repair is about 5%. There's some other things that can respond. These are called the Paul-E mutations, and this is about 0.3%. Some patients, but we need to know more about it, with CDK12 loss, at about 6.9% of patients can respond. High tumor mutational burden, about 6.6% of patients, 6.6% of these tumors. And then some rare things like PD-L1 amplification, or also what we call the 3' UTR, very low percentage. But nevertheless, we do screen for these things because on occasion, if you find them, we can have these absolute dramatic responses with immunotherapy. So we like to use it. We can only use it in patients who have a mutation. If you don't have a mutation, the response rate is extremely low, very, very, very low. Now, one of the things that we do that has been informative is try to understand the tumor by getting liquid biopsies. And this is quite interesting to me. we can actually sample the tumor DNA by a blood draw. And we're getting more and more information about this. And the question is, well, can we use this to benefit patients? The answer is yes. We now have an FDA-approved liquid biopsy for BRCA and rucaparib. That's brand new, very innovative, to be able to do a blood test, to be able to look for the tumor DNA and then give a drug based on the tumor DNA blood test. So that's quite interesting. There are probably going to be more FDA approvals, and knowledge is evolving very rapidly here. Quite interesting work, I think. Now, this example from one of our patients, and these little different colors are the different genes that are altered. And here you can see something called EGFR amplification going up and then down, depending on when we sample. Here's one called a PTEN mutation going non-detectable to detectable to non-detectable. And there are other mutations we can see in this little color-coded thing. But the big mutation, the one that's kind of blue here, is BRCA2. And here, this is a particular mutation, got a lot of the nomenclature, H173 frame shift. 46% of the tumor DNA is actually this one mutation. So what do we do with this patient? We put them on a PARP inhibitor. And so that's the way that we use the circulating tumor DNA in order to drive treatment decisions. Now, this is just another example. This is one of our patients that we use the high-dose testosterone. We published this about 4 years ago. And here we're looking at things like P53 gene and the AR amplification. We put on the high-dose T and we see that these genetic abnormalities go away. And we put the patient back on abiraterone, and the PSA comes down, by the way. The PSA declines on high-dose T and then can decline again on abiraterone. We're resensitizing the patient. The mutations come back, we put them back on the high-dose testosterone, and the mutations go away to some extent. This mutation goes away. So we're able to map and track the mutations that occur, and I think possibly that this can make us into better physicians, because now we understand the molecular genomics, we understand how things are altering with therapy, we have serial measurements, and we can alter our therapy in part by some of the mutations we see. So that's kind of part of the future, but we're actually doing it right now in our clinic today. Now, PSMA binding molecules are important. I talked earlier about PSMA imaging that was actually done with PSMA 11 or maybe PSMA INT. But we can use these chelates. These are called chelators right here because they bind metals. We can stick a radioisotope such as lutetium-177 or actinium-225 into this chelate and then deliver the radiation directly to the tumor. And we can see that they're pretty good PSA waterfall plots. These are patients that have PSA declines that have occurred. Now, you say the median survival here is 12.7 months. These were far advanced patients. These were difficult patients, but nevertheless, we're getting responses. So this is an important potential new therapy. Now, before we have a therapy we can bring to all the patients, we've got to do the proper trials. We're doing the proper trials now. This is the VISION trial, and I happen to be one of the PIs, myself and a German individual, are the co-PIs in this trial, and we're treating patients with best supportive care plus the PSMA lutetium-177, and we're going to try to find out whether or not people benefit from that by looking at progression or survival. And I think that we'll have results on this next year. We don't know for sure, but I think we'll have results next year. Very important trial. If we don't have good phase 3 data, the FDA will not approve it. And this is a trial that I think has a possibility of providing data for an FDA approval. Now, one of the things I talked about with lutetium-177, that's called a beta particle. It's a little electron. We also have alphas. Alphas are bigger particles. There are things like helium nuclei. There are 2 protons, 2 neutrons. And there's been some very provocative data with regards to using alpha particles like actinium-225 with PSMA targeted therapy. And here you can see a patient who's a very tough patient with a PSA of almost 3,000. Whose PSA goes down to undetectable. Now that's an anecdote. This isn't every patient, but nevertheless, there's some good stories out there with the alpha particle, and we certainly try to develop. We'll have an alpha particle protocol here at Tulane very, very shortly. We'll hopefully within the next month or so. Now, as it turns out, in summary, and I'm pretty much through giving this big overview, prostate cancer is one big disease. You can't just treat it as one disease. Some people can be watched. Some people have a deadly disease. Some people have metastatic disease. Some people have a disease that has failed hormones. Some people don't. It really is hard to make generalizations about this disease. And in fact, if you hear somebody say, oh, well, prostate cancer is this or prostate cancer is that, it's probably not true because it depends so much on the individual. What about their genomics? What about their age? What about their comorbidities? What about the extent of spread? What about the pace of the disease? What about the PSA doubling time? What about their Gleason score? All of these factors need to be taken into account. I'll simply say that if you have advanced disease, our strategy is try to live a little longer and then depend on and hope for the treatment will be better in the future. And it's interesting. I've been in this game for 30 years and I've seen tremendous advances, and I'll remain optimistic for the future because the research is getting better and better. We're smarter than before because our tools are better than before, and there are good people working on this. So I know I don't want to be Pollyannish. I don't want to simply say that we're great. We're not great, but we are making progress. But I do want to emphasize as much progress as we have made, we still have a long way to go for perfection. So we need to keep working on it. And that's why research is so important, not only for me, but for you. Prostate cancer research is critical for the progress we're going to make in the future. And that's my priority in addition to taking care of patients. Thank you very much. That concludes the lecture. I hope you've enjoyed this big view of prostate cancer. It's my understanding